everything they've done for our patients, but also for me personally, helping me kickstart my research efforts in Chordoma. So it's truly an honor to be here with patients, their caregivers, and our colleagues. My name is Matei Banu. I'm just recently joined Stanford as a faculty with a focus on skull-based tumors, and particularly I'll focus on clinical trials in skull-based tumors and some basic science research along with the clinical efforts, of course. I'm going to talk to you about two things today. The goals, the surgical goals in skull-based chordomas, which are quite different in terms of the approach from the spine chordomas, and about some of our research efforts to try and change the treatment paradigm after the surgery in terms of the systemic treatments, which are very limited right now. So just a little bit about myself. I trained at Columbia, as Josh mentioned, where sort of the focus was to do safe surgery, but without really pushing the boundaries in terms of how much of a resection we get. I then moved on to MD Anderson in Texas, where the mindset was very different. It was all about trying to get everything out as safely as possible, but really pushing that surgical boundary. And then I got here to Stanford, where the focus was equally about really pushing the surgical boundaries while doing really safe surgery. We've had some excellent outcomes throughout the last year, so I'm looking forward to pushing those surgical boundaries. I'm going to talk to you a little bit about that. First, just a little bit about all the people that sort of guided me towards this path. First, my mentors at Columbia, who were really instrumental in guiding me towards my path towards skull-based, which is a very eclectic and somewhat inspiring field. And then my mentors at MD Anderson, who were phenomenal surgeons, really pushing the boundaries as well in terms of what one can do surgically for these patients. And then finally, obviously, here at Stanford with Dr. Fernandez-Miranda, who is my mentor and partner, and Dr. Lim, who is our chairman, and also the guy who is guiding me in my research path forward. A little bit about chordomas. You've heard a lot of things. These are some pictures I took last week at the American Museum of Natural History. So, fun fact, chordomas and tumors of the bones have been noticed in dinosaurs as well as Neanderthals. So these have been around for millions of years. Not sure about chordomas. Chordomas have started in mammals. Actually, the mammal who has most often chordomas is the ferret. I didn't know about that, but it's just to say that chordomas are, and cancers in general, should be considered sort of a developmental disorder, right? Cells are supposed to grow. Chordomas start from what we call notochordal remnants, which are just embryonic remnants that are there because they were still there from when the embryo formed. So they're just sort of doing what they're supposed to do, which is grow. But we need to better understand them, so I'm going to talk to you a little bit about how we tailor treatments for patients based on the anatomy and the biology of the tumor, which are two very different aspects. So a few things. Skull-based chordomas, like we were saying, are very different. They're in a very deep location at the base of the skull, very difficult to access. They can grow anywhere along what we call the clivus, which is this bone at the base of your brain that can be very difficult to reach. And you can see it here on the left-hand side, that little yellow circle. That's usually where skull-based chordomas arise. And this is just a picture to show you how much real estate there's around these tumors at the base of the skull. There's all these important nerves, there's brain, there's arteries, there are veins, there are very important structures that you just cannot disrupt to get there. So we've sort of developed over time different methods to get to that point. And that also implies that we need a multidisciplinary team to do it surgically. This is even before we move on to the next stages of treatment. And these are just some of the people that are usually involved in a surgery like this. We have skull-based neurosurgeons, of course. We have rhinologists who help us with the surgery when we do it through the nose. We have spine surgeons frequently who, if the tumor extends into the upper cervical spine, if you remove the tumor, the spine is unstable, so we need their help with stabilizing the patients afterwards. We have autologists who sometimes we need them for complicated lateral skull-base approaches. We have head and neck surgeons because sometimes the reconstruction means we need to do what's called a free flap, which is taking tissue from the thigh or the forearm and transferring it and anastomosing it to cover that defect. Sometimes there's involvement of the eye, so we need the oculoplastic team. And of course, there's management afterwards where we need multidisciplinary care, including our endocrinologists. So this is sort of how it looks in the OR. It's a very busy place. I just wanted to give you an idea. On the left-hand side, what you can see is sort of the microscopic approach, which is a transcranial approach that you sometimes need for this. And then on the right-hand side is a endoscopic approach where we use this pen-like camera. We go through the nose to operate to get to the base of the skull. We work together with rhinologists. It's a team. It's sort of like a dance where they show us what we need to do. We can use both hands. We use micro-instruments through both nostrils. It's a very interesting dance, but it's all about the team in these cases. It's a single surgeon cannot do this case, and these are 12 hours plus surgery, so we really need everybody's help in this. So this is just a sort of sneak peek in terms of how it looks. You see this is the endoscope. It really provides a very panoramic view. This is looking through the nose. It gives you a 360 view, magnified view. We use these micro instruments to carefully cut. You see how we enter the dura there. Very thin instruments, fine movements to try and dissect it off these vessels. This is just to give you a thought about how complicated these surgeries are and why having expertise and training is critical. And it's not just about the expertise and training, but it's also about pushing the boundaries and about how we develop these surgical techniques. And Dr. Fernandez Miranda's group and together now we're sort of pushing the boundaries in terms of the anatomical studies. So we in his lab, we've been doing this work in terms of seeing how we can expand this approach, especially through the nose, and describing the local anatomy. And it's all about millimeters or even smaller distances in terms of identifying these important vessels, these important structures, understanding how you can inch forward towards the tumor so you can get what we call a supramaximal resection, and I'm going to talk to you a little bit about that. So these are just some papers where early on in the 2010s we were describing sort of the anatomy and trying to understand the base of the skull better, especially from the endonasal side of things, because it's a totally different view and a totally different access compared to the transcranial approach. Sometimes we need combined approaches and we operate together in teams. So furthermore, to really get to that technical expertise, you need to start developing not just the technique, but also the instrument. So he's actually developed special micro-instruments that we use in the operating room here at Stanford to try and get to it. Sometimes these tumors go into what's called a cavernous sinus, which is a pocket filled with blood at the base of the brain that also has many, many important nerves, and a big vessel that's called a carotid artery, which brings the blood supply to your brain. Now, to get into that space to try and get tumor out, many people just leave it there and radiate it. But we really believe in the power of surgery, as you've seen multiple times today. Getting the grossal resection, or even more so beyond that, is important in terms of outcomes. So we're really trying to push that, and we've developed techniques to try and get into that cavernous sinus safely, navigating the carotid artery, navigating the nerves without deficits, being able to resect the tumor in there. But again, it requires expertise, practice, going into cadaver lab, refining your technique, and really designing instruments specifically for this. And this year, I think I appreciated more than ever how important it is to have the right tools, but also the know-how how to use them. And this is just more in terms of some of the papers we've had over the years, how we've changed the mindset in terms of approaching these tumors. And then towards the right-hand side of the screen, you can see that's developing new reconstruction techniques, because at the end of the case, you have this giant hole at the base of your skull. How do you reconstruct this? You need to bring in vascularized tissue to cover that so that it heals properly. Otherwise, you can have really debilitating side effects from it. especially because we know that radiation comes afterwards that can lead to significant comorbidities. So bringing in vascularized tissue really makes a huge difference. And we've developed techniques from, like I was saying, the free flaps, where we work with our head and neck colleagues, to designing rotational flaps, local flaps, that we take from under the scalp and we sort of tunnel it through the mouth and then end up at the base of the skull. So it requires a lot of expertise, as I said, and many people who know how to do these things. But the outcomes are actually better with these big teams and big surgeries. It makes a huge difference. So this is sort of just pointing the concept of supramaximal or radical supramarginal resection, which is we don't just want to remove the tumor. We know there's microscopic disease surrounding it. We know they're radio-resistant, as you've heard from Dr. Pinnicker. So we want to try and push the boundaries as much as we safely can, get into normal tissue, drill the normal bone surrounding it, which could have microscopic disease. So trying and removing everything. You cannot remove it on block, like Dr. Desai was mentioning, in the skull base. So that's why we're sort of adjusting our techniques in terms of coming widely around it as much as we can and sort of bringing the concept of on block to a very tricky spot at the base of your skull. And then this is just more about the reconstruction techniques, showing you how we need to take flaps from everywhere to try and cover that defect to avoid complicated postoperative courses and infections, meningitis, and other side effects from this surgery. This is just a quick video. I'm going to skim through it. I want to point a few things so you can see. This is just looking from above. You can see the tumor in white there at the base of the skull. This is again the view that you get with the endoscope, which is a very nice panoramic view. We use drills to drill the bone. That's some of the tumor that we remove. Then we use micro instruments to again try and come around the tumor slowly and developing that plane. And then what I wanted to point out is this area right here. It's not just that we get the tumor from inside the bone, but it invades into the dura and it gets close to very important blood vessels, like the basilar artery, and there's literally life flowing to that vessel. If you take even the tiniest of vessels off the basilar artery, the patient can be in a coma forever. So again, having the expertise, having the instruments, having the know-how is critical to avoid really bad side effects from these surgeries. In terms of the current management paradigm, you know, in recent years we've developed new understanding in terms of the biology of these tumors. So it seems that there are different groups and of chordomas. They behave differently from a biological standpoint. So we've been doing some of these studies together with Pittsburgh and MD Anderson in terms of looking at the biological makeup, specifically at specific mutations, and then sort of tailoring treatment afterwards based on that. If there's incomplete resection, but the patient has a good prognosis in terms of their molecular makeup, then we may defer radiation for the time. But if they are part of this worst group where there's, even with growth stone resection, but their biology indicates an aggressive tumor, we just go ahead and radiate. So this is sort of where we're at now, and I just want to switch gears real quick and discuss some of our research and how we envision changing the paradigm even further. So this is the top part is the current surveillance paradigm. We have a primary chordoma, we take it out, we do all these molecular studies, a few things that we check. Then we have residual chordoma occasionally. We know there's microscopic disease. It will eventually come back. We do proton therapy, radiation therapies, targeted therapies, as you know, sometimes immunotherapies with limited success, unfortunately, and then the chordoma recurs, and then we're sort of at a standstill. We don't know what to do next. But how we want to change is try and predict how the tumor is going to respond. So what we're trying to do now at Stanford is take some of this tissue and study it extensively. Not just with two things that we're looking at, but extensively what we call multi-omic studies, which is using novel technology to study it from a RNA perspective, DNA perspective, chromosomes, genes, metabolism, which is very important. I'm going to briefly touch upon that. And then sort of decide how that changes our treatments. Should we try something else in this patient because this tumor is special? Every tumor is very different, right? It could be a tumor that's slowly growing, or it could be a super aggressive tumor. They all look the same in the operating room. frequently under the microscope, they also look the same. So changing the way we do things after the surgery is as important as changing the way we do things in the operating room. And this is a busy slide, and just want to show you a few things that we're trying to get started here at Stanford, which is the concept of using organotypic avatars from patients, taking the tissue from patients from the OR. We're going to give some to the pathologist. We're also taking it to the lab, and then we're going to use Dr. Demirci here in the top. He is a biomedical engineer who's developed a microfluidic platform. We can actually grow this, and I have a paper on other brain cancers where we're doing similar things, where we're growing tissue from the tumors from brain cancer, and then we were studying different drugs on that tumor, then using multi-omic studies to see how the tumor cells in the microenvironment responds to those treatments, to then predict how the tumors will respond to those treatments, or if we can come up with alternative ways to treat these tumors. And then Dr. Dixon here at Stanford at the bottom, he's discovered novel forms of cell death. All these chemotherapies that we have, they induce a form of cell death that's called apoptosis. But it turns out that there are many other forms of cell death that we have no idea how they may impact cancer care. So he's developed new drugs to try and induce this different types of cell death. Ferroptosis is one of them. He's discovered another one that's palmoptosis. The nice thing about these new forms of cell death is that they rely on the tumor cell's metabolism. And you know, some people think it's just glucose that the tumor cells use. Not even close. They use all sorts of, they use fatty acids, they use fats, especially when they are slow-growing tumors, because that's what's available to them, more so in the brain than anywhere else. So really leveraging that vulnerability would be a very smart way to go about. And then in terms of the new treatment paradigm, this is sort of what I'm envisioning moving forward, maybe 5, 10, 20 years from now, but we're really pushing, and with the Chordoma Foundation's help, hopefully we'll get there, is you know, we have a primary chordoma, we take it out, we take it to the lab, we do these avatar slice cultures, we treat it, we study it, we choose a drug or a combination of drugs, move on to the next stage. Again, the tumor recurs, we do the same thing, we come up with it's a different tumor once it comes back, right? It's not the same tumor. So we always need to adapt as the tumor adapts to our treatments. And this is some of the work that I've started doing with the Chordoma Foundation's help with MD Anderson. We have about 30 patients where we have the primary tumor and the recurrent tumor, and we're studying them using these novel technologies. This is called spatial transcriptomics, and then spatial metabolomic studies to just sort of understand how the tumor changes both at a molecular level and on a metabolic level as it progresses. And this will allow us to come up with biomarkers, ways to just say, okay, we've studied these are the things that are upregulated in this tumor. We know already from our previous studies how it's gonna respond. And these biomarkers are gonna be key in future clinical trials. Some of this lab work, this is Dr. Petrich's lab here at Stanford. They've been studying with us some of the metabolic pathways because they're really crammed in terms of the availability of metabolites locally, so you can actually hit them where it hurts, which is their metabolism. They can adapt, but they can adapt slowly because there's only so many metabolites locally that they can use. So one thing that we've noticed is they like fatty acids and fats, and then we've tried some of these are just some cell studies to show you and some nice pictures to show you that as the radiation hits the tumor cells, they again change their metabolism from glucose to fatty acids. So then they're sort of cornered at that point. And you can use a drug that's called an enifenostat or other drugs that are currently in development. This one is actually FDA approved to really target those cells that are resistant to radiation, but they're sort of cornered because of their metabolic needs. And then this is my last slide, just basically showing you how complicated the tumor microenvironment is. In gray, you have tumor cells. You have CD8 and CD4 positive T cells. These are immune cells that are there to kill the tumor, but if they don't work properly, and they usually don't because of the tumor cell, just them being present is not going to be enough. There are many other immunosuppressive cells in the tumor microenvironment that we're trying to target with different treatments. So this is just sort of an overview about sort of how we're going about this. It's not just about targeting the tumor cells, but also helping the immune system react to the tumor so that when the tumor comes back, the immune system already knows that there's something up. Because right now, the immune system is very blind to these tumor cells. It doesn't know that the tumor cells are there, so it can barely react. It's pretty crippled. So together with Dr. Lim, we're trying to sort of make that immune system be more effective. Just a few conclusions. Supramaximal resection can lead to progression-free survival and overall survival. We just got to get our techniques down, and expertise is key for that. They should be treated as always centers of excellence with high volume, and multidisciplinary teams are key. Anatomical knowledge and technical nuances are also very important, as I try to show you. And then from the research perspective and the systemic treatment perspective, biomarkers should be tailored to postoperative management. The high throughput drug screens that I described to you, we're just starting, but I think it's something I'm really excited about, using these patient-derived organotypic avatars to try and test drugs and then hopefully bring those drugs to the patient. And then these new ways of analyzing the tissue with multi-omic studies will help us even better personalize treatments. And then these metabolic vulnerabilities in conjunction with immunotherapy could lead to a total different paradigm shift in terms of how we treat these tumors. So it's all about, the path may be the same, but like sort of changing the way we view it may be the key to getting better outcomes here. Thank you very much.